So next up, now that we kind of have a little bit of a basic understanding of male and female fertility, is actually to discuss exactly what happened when we all went through cancer treatment, whether it was surgery, chemotherapy, or radiation. And here to discuss that with us is Dr. Jim Waisman, who is a very well-respected oncologist from BreastLink. He has specialized in breast cancer treatment and care for many, many years, and certainly can cover the gamut of what exactly happened. And then once we go through that, we'll be able to dive in a little bit to what's next.
Terrific. Alice, thank you so much. Thank you for Fertility. Thank you for inviting me. Thank you for being here. I just want to add to the tribute to Alice and Fertile Action. Those of you who have not read a book, it's just won the Pulitzer Prize. It's called The Emperor of All Maladies, written by a medical oncologist named Mukherjee. Gives the history of cancer over the last 60 years. And one of the things that was most interesting in that book is the importance of advocacy, because starting back in the 60s, people who had cancer were out there yelling and screaming at congressmen about the importance of funding cancer research and eliminating smoking and things like that. And those people were courageous people like Alice. So really this kind of thing can't move forward unless there are people like her and like this group. So thank you for having me. Let's see. I'm just going to repeat some some things, but this was discussed by Dr. Chung, but this is a very complex issue, the feedback loop between the ovary, the pituitary, and the hypothalamus. But it's important to understand that this is a complex area, and I certainly support the idea that once you get far enough along, you really need a reproductive endocrinologist to help steer you through this, but issues of stimulation, relationship of the LH, FSH, estradiol axis, the pituitary, and the timing of when these hormones are maximally evaluated in a fertility workup is critical. So I wanted to talk about the demographics, and I'm a breast cancer medical oncologist, but I thought it was important to highlight these issues. 5 to 7% of invasive breast cancer, which is really what we're talking about, because that's the only time that we're talking about interfering agents that will limit fertility. That's about 11,000 women per year occur in women under 40. It's not a big subset of women, but the truth is this is where fertility issues surface, and most of the women are between 30 and 40. And if you remember from Dr. Chung's curve, fertility begins to drop after about 35, and most of these women are between 35 and 40. Less than 10% of the women who develop breast cancer, less than 40, have children post-diagnosis. So unfortunately, this is a major issue, despite surveys showing that 50% actually do desire children. I've just handed out, I don't know if it's been passed around yet, there's a pink sheet handout that just came out in our major journal, Journal of Clinical Oncology, that sort of supports what happens to women as they go through the crisis of breast cancer and are confronted by the cancer itself, whether they're going to live or die, what kind of surgery they're going to have, are they going to have chemotherapy or not, and then having to deal with the issues of fertility preservation. We as physicians do not do a good job. We do not. The data shows that there's a poor educational approach by medical oncologists in particular. And really, if you ask women, only 50% of them feel that their fertility is even adequately addressed. Of these women, 2/3 less than 40 will have stage 2 disease. That's pretty much the standard of when chemotherapy is needed. Larger tumors, more than 2 centimeters, some with, but some without positive nodes. 2/3 of these ladies are hormone positive and need tamoxifen or GnRH agonist, drugs like Lupron. that prevent ovarian stimulation. So even though they may not have had cytotoxic chemotherapy, they're going to have a drug like tamoxifen in the majority of patients as recommended to, and you don't get fertile while you're taking tamoxifen. So what are the key questions that need to be answered? And we can deal with this in the Q&A, but clearly the major issues for medical oncologists to answer and dialogue with patients is, how do we choose these drugs? How is adjuvant therapy selected? How much will and these are the questions you should be asking us. How much will treatment reduce recurrence? What is the likelihood of the loss of fertility? Will fertility preservation lead to an increased risk of recurrence? And will pregnancy lead to an increased risk of recurrence? So I'm not going to give all the answers now, but I think these are important for the discussion points further in the discussion today. And I would just add to Dr. Chung's topic, highlight that the age of the patient is the clearly most significant issue in terms of risk stratification. Certainly by 38, the issues of natural fertility have dropped off significantly, and unfortunately that represents a significant number of women who still are interested in having children who have breast cancer. The type of chemotherapy is critical. I'm going to show slides about this a little bit more. The length and the dose of the chemotherapy regimen, the measure of ovarian reserve, and that's an endocrinologic question of measuring hormone levels, and the need for anti-hormonal medications and chemical ovarian ablation. So when you talk about the risks of infertility, that's the specific issue, and that's why those questions as to making decisions based on benefit versus risk is a critical issue. I've boiled down breast cancer into kind of these subtypes. This is essentially where chemotherapy has established in breast cancer benefit. Triple negative women, that's women who have estrogen, progesterone, and HER2 negative breast cancer, and that represents about 15% of patients. Patients where the tumors are HER2 positive, and that represents about another 20%. So that's 35% of women. These people absolutely have had established benefit to chemotherapy, except for the very, very tiny lesions, say less than 5 millimeters, and that represents a very rare tumor type. And even in those cases, there's an argument in the country today about the benefits of chemotherapy. We call this next group luminal B. It's a new genomic classification. Those patients whose tumors are estrogen positive, progesterone negative, and have a high proliferative index or high Ki-67, pretty much those patients need chemotherapy. And then patients who are ER positive and have what we call high recurrence scores on molecular profiling. And those of you who know about things like Oncotype DX and Mammoprint know that we send tumors for evaluation of their molecular characteristics. And in patients who have the highest recurrence scores, and that's over 31 for Oncotype DX, the issues of chemotherapy benefit are pretty well established. Low recurrence scores, no. And this has been a huge advance since 2004, because previously we were giving chemotherapy in breast cancer to women just based on size of the tumor. Anything more than a centimeter in a premenopausal woman. We're not doing that anymore, fortunately, because we realize that chemotherapy benefit in a low recurrence score patient with low molecular profiling characteristics is not going to benefit. 2/3 of women in major studies have been spared chemotherapy because lack of benefit, and that's a good thing. Do they still need anti-hormonal therapy? Yes, they do. Do they have compromise in fertility during that period? Yes, but they don't have permanent loss. These are acronyms. I won't go through them all. Some of them are recognizable to you. These are the standard chemotherapy approaches in the adjuvant therapy of breast cancer. And what I want to kind of highlight is anything that has a C in it means that the patient's receiving Cytoxan, which is pretty much standard in all major chemotherapy regimens. The problem with that drug is it's probably the most inducing, chemotherapy-induced ovarian failure-inducing, CIOF. So you can see in most of those drugs, CMF, AC, FEC, AC followed by Taxol, those patients, particularly less than 40, have a very high CIOF, chemotherapy-induced ovarian failure rate. And if you look down at the very bottom, the T, those are the taxanes, and most of us feel that if you receive a taxane, it's at least as inducing ovarian failure as Cytoxan, if not more so. In our current regimen, the standard of care in most patients avoids adriamycin and uses a drug combination of Cytoxan and Taxotere, and that is a double whammy to fertility. Now, I just want to quickly talk about what I think the future is, and we talk about this in oncology: personalized medicine, tailored therapy, and tailored risk assessment. And I think this is a complex slide, but what we're looking at more and more is the ability to subcharacterize patients based on genotyping. And here you see an interesting characteristic of the cytochrome P450 system that metabolizes or catalyzes Cytoxan or cyclophosphamide. And in this, you see this CYP2C119 genotype. And this is just a kind of a list of women who've had lupus, systemic lupus. And what happens here is in these patients, if they don't have this CYP19 genotype, then they have a higher incidence of premature ovarian failure, whereas if they do have this unusual genotype, they don't. So if you compare that to the initiation of chemotherapy, the length of chemotherapy, the age, the number of cycles, that genotype is the most important discriminating feature for the development of premature ovarian failure. So it may be that the customization of fertility evaluation in the future will be really the defining the personal characteristic of a woman genomically, and match that with the molecular profile of the tumor so that we appropriately select patients and respond to them appropriately where fertility preservation is appropriately assessed as a critical quality of life issue for women. Thank you very much.